Most people do not want to release the information that they are infected. They feel they're stigmatized.
The overall goal of chronic hepatitis B management is to prevent fibrosis progression and liver-related complications. Hepatitis B surface antigen serial clearance is an important endpoint.
Quantitative testing predicts infection phase and functional cure.
Welcome to EASL Studio, your weekly hepatology broadcast news. In this episode, we're going to be talking about hepatitis B, rethinking patient conversations. And this really has come across because we've just had the publications of the new EASL clinical practice guidelines on hepatitis B at the EASL Congress in Amsterdam only a few days ago on the 10th of May. So today I've got a really exciting panel, and I'm really looking forward to this conversation about rethinking patient conversations with hepatitis B. So I'm going to ask the panel to introduce themselves briefly, and then we'll kick off. I'm going to go in order of people appearing on my screen. So Markus, can you please introduce yourself?
Yes, hello everyone. My name is Markus Cornberg. I'm from Hanover Medical School. I'm clinician, deputy director of the Department Gastroenterology, Hepatology, Infectious Disease, Endocrinology. And I'm here because I had the privilege to chair the panel of the HBV CPGs.
Lovely. Thanks, Markus. Sital, you're next.
Yep. Hi, I'm Sital Shah. I'm the consultant pharmacist for hepatology over at King's College Hospital in London.
And Thomas.
Hi, my name's Associate Professor Thomas Tu, calling in from Sydney. Not quite Europe, but we were in Eurovision, so that's close enough. I'm a molecular biologist by trade, looking at cccDNA and integrated hepatitis B. I also live with hepatitis B myself, and also am a patient advocate. Thanks.
Thanks, Thomas, and thank you for joining in Australia so late. And Sue.
Hi, everybody. Glad to be here. My name is Sue Wang. I'm an internist, and I work in New Jersey for Cooperman Barnabas Medical Center, and I'm part of the Rutgers New Jersey Medical School, and also, like Thomas, somebody living with hepatitis B, and I was honored to be part of the Delphi panel and working with Markus and the group on the EASL guidelines, and I was formerly president of the World Hepatitis Alliance. So very glad to be here. Back to you.
Great, thank you very much. So you can see we've got a real breadth of expertise here in the panel, which is really what we need to have this discussion. So Markus, perhaps you can kick us off by just telling us the headlines from the new CPG.
Yeah, the headlines. So I think the CPGs are very comprehensive. We have 10 chapters overall, so everything concerning hepatitis B is in there. I think the most weighted chapter is the treatment indication. There was a lot of debate on the extension of treatment criteria. We had debates on gray zones, intermediate phases, which are not good terms, I think, also in patient communications. And we tried to discuss this, to solve this issue. I think we are not yet at this stage because we have no functional cure, which is also not a nice term in general. We have no cure like in hepatitis C, that we are not at this stage to treat everyone and cure everyone. So we still at the phase where we need to think about whom to treat immediately with a strong recommendation and maybe who does not need immediate treatment, low replicative HBV infection, normal ALT values, and so on. And I think we need to discuss this. There is, I think, an important discussion also in the guidelines about shared decision making, which is becoming more and more important, especially if we talk about personalized medicine to treat those who are in need and to explain also the patients and the people living with HBV infection, what is the risk for HCC development, where can we intervene early, and I think these are the important discussions we need to talk today.
Yeah, absolutely great. So thanks, Markus. That's really, really concise. So Thomas, perhaps I can come to you first. As someone living with hepatitis B, who's not a clinician, what do you make of these new guidelines, and what's your initial impression?
Well, my initial impression is, as Markus says, it's 10 chapters of very dense material, and I would say, great job, Markus, and the whole group. But we're halfway there, really, in terms of conveying this and getting that co-decision making a reality. We still need to translate these essentially into something that the patients can understand, and making sure we're meeting patients halfway and informing them really in language that they can understand to be able to make that decision in an informed way. But yeah, I'm really glad about the patient-centered and person-centered care that's being incorporated into these guidelines.
Sue, a question to you.
Sure. Yes, I think this is a huge step towards treatment expansion and really simplifying things, but also making it really comprehensive. Because if you look at the diagram, it's remarkably simple, despite the 10 pages of dense text.
Yeah.
So I think there are some really good takeaways. And I think, like Thomas said, the next step is to really develop different formats of this that are easier to understand. But I think what we have already, like with that diagram and some other really great tables there, it does allow for more permissive and more individualized treatment, and that kind of bringing up that shared decision making is going to be huge for more kind of taking in patient preferences and values, because somebody could have the exact same clinical scenario, same labs, but completely somebody wants treatment and the other patient is going to want monitoring, right? And we need to allow for those differences.
Sure. No, I think that's absolutely right. And I think Markus and I had a conversation in Milan about a year ago where, Markus, I think you said one of your stated aim was that if anyone wants treatment, the guidelines should enable that to happen. And I think the way they're written, it does enable them to happen. So Sital, I think it's an interesting thing for people who manage people with hepatitis B, because we will have a large cohort of our patients in clinic, maybe 20-30%, maybe even more, who for years have been sat in the 2,000 to 20,000, without getting too technical, range of viral loads, who we haven't treated, who now we're going to go back to and say, well, actually, the guidelines have changed now, so we do want to treat you. So that's a conversation that's going to have to be individualized and personalized. And as clinicians, we're going to have to be open to people saying yes and people saying no, and not assigning any sort of moral judgment to that decision, whatever the shared decision is. And that's going to be tough for some people. But how do you think you're going to approach this? Have you started thinking about it?
Yeah, no, definitely. I think there's really nice bits within the guideline that's quite clear on the benefits of starting an antiviral therapy, the benefits of regular surveillance with liver ultrasound. And I think sometimes we forget some of these patients have been in clinic for such a long time. They've almost forgotten why they're undergoing liver ultrasound scan in the first place. And I think actually now is a good time to start revisiting some of those basic bits of information and having those conversations to begin with. I think obviously as a pharmacist, we've always been very used to that shared decision making when it comes to taking medicine. So, it's about actually empowering the patient with information so they can make an informed decision. So some of the benefits of it, and it needs to be personalized. So, there will be some patients that come to me who've sort of refused treatment for a number of years for various reasons. And it's about revisiting those reasons. If we've got someone, which I had the other day, who lived in a very big shared household, do they really know about their risk of transmission? Because some of them are more worried about others than themselves. So I think it's quite nice to start these conversations again, even if you think your patient's been, well informed over the last 15, 20 years of coming to clinic. You'd be surprised that they might not actually remember. They just come in for the sake of it. They're like, yep, I'm going to get my blood test, going to go home, it'll be fine. So I think now's a really good time to start having those, refreshing those conversations.
Yeah, I think that's really important, and going back to basics and exploring And so, Markus, how about you? Have you started having those different conversations already? And what's your early experience?
Yeah, I mean, you have to differentiate, of course, the experts that know really the natural course and the patients very well, and those who maybe not the experts, and they, if you're too detailed in the guidelines and you're not this expert, you may make mistakes. And I think that is the point. I think for us in our clinics, we basically do not really change. We did it already in the past and discuss it with the patients. We know also in those individuals who have between 2 and 20,000, maybe always normal ALT, the data from Europe at least, that may be different in Asia, that they have a rather benign course. And we are more now on the way, if the virus is always fundamentally a problem, right? If you have replication, you want to suppress this. And I think we have more and more confidence also with the safety and generics of the drugs to treat those individuals. But still, they have a rather benign course in the setting you just pointed out. So we talk to the patients, we inform them, we do our regular workup. But I think for those who are not so experienced, this is so important that you better have a low threshold to initiate treatment, not to oversee something, right? Not to let them go and there is maybe a patient that has had an unrecognized fibrosis, advanced fibrosis, and so on. I think this is so important that you do not miss the opportunity to treat. Yeah, if you're an expert and you know exactly what you're doing, I think, and therefore our recommendation, you can treat, you should treat. We need to know our patients where we should treat, and we need to know our patients where we can treat and maybe defer treatment. I think that is very important.
So Sue, I think Markus makes some really good points about expertise, and I know you guys in the United States came up with some quite simplified guidelines based on the current AASLD guidelines that probably are about to change.
Yep.
To try and simplify the chart. I think the chart that you already mentioned is relatively simple, but it's probably me talking as a hepatologist who's used to treating, hundreds of people with hepatitis B. How do we simplify it further? And what's the balance? So I think in Europe, largely hepatitis B treatment is delivered by specialists. I think elsewhere, and we have to have the conversation about, in fact, we need to expand the number of people treating if we're going to treat more and more people, because our clinics won't be able to cope. But where do you think, what lessons need to be taken to enable other people who aren't specialists to have that conversation? Maybe what's your personal experience on both sides of the fence as a primary care provider, but as someone living with hepatitis B? I mean, are you always given enough time when you go to clinic, for example, to have these discussions?
Yeah, those are really good points. Yeah, and I think we have to take a step back and realize that we have such big gaps right now in diagnosis and treatment. When we're talking about trying to get to elimination by 2030, that is our biggest place where we're lagging, right? Treatment, only 3% in the whole world, have been given hepatitis B treatment of those who have hepatitis B. So we realize we're already, we need these guidelines to enable us to really do that task shifting, that decentralizing. That's going to be important because not everybody can see an amazing Hep B specialist like Markus or Ahmed, right? Not everybody has access to that, especially in areas of the world that are really, really burdened with Hep B, right? In Africa, Asia, and a lot of places, even in the US, right? I think even in developed countries, there are areas that are really resource poor, right? So we have to be able to shift these to primary care because primary care is seeing patients already regularly every 3 months for their diabetes, for their hypertension. And true, we are very, strapped for time. But when I start talking to other providers, I tell them, honestly, my Hep B patients take very little time once I get them going, right? I think your initial investment is really having that first conversation, once you're talking about treatment that requires some education, soliciting their preferences and opinions as part of that shared decision-making. You do have to make that first investment, but just like with other diseases, once they get on a roll, like it's really not a whole lot of time. And like was mentioned, we do have to revisit this. And what I often will say is, hey, things are changing. They know I'm going to meetings and they want to know what's happening, right? So people understand science is changing. There's new research. And so when I talk about Hep B integration and things that we're finding that people with normal ALTs often do have fibrosis, right? Those little bits of information I think are helpful. And I have to say, Thomas knows there's a number of us who are Hep B patient advocates living with Hep B who are listening to a lot of the data. And I would say, like, a lot of us, after hearing a lot of data for ourselves, have chosen to start therapy, even though we don't fit into the criteria. So I think that tells you something, right? Those of us are hearing enough information to get us concerned. I feel like educated patients, and this is not everybody, I definitely don't speak for everybody, but if they get enough information and they are concerned about liver cancer transmission, often do choose to go on therapy. But those are often the ones who are going to be compliant, which we know is really important, taking your medicines every day. So it is a journey, I think, in terms of following the patient, educating them so that they have the tools that they need to make the decision. But I do think, yeah, and we are actually about to update those primary care guidelines based on all the new guideline updates. So, stay tuned for that as we move forward. So I'm excited about where we're headed with this.
Great. So Thomas, I mean, similar question to you. I mean, I know you do a lot of community support and you have a Facebook group where people can ask you questions. I'm interested in the cost element of this. So of course, as we expand treatment, we're going to ask people to have more and more out-of-pocket costs. And there's this concept in the TB world of catastrophic costs, that actually you get to a stage where it is, TB therapy can be life-saving, but people aren't able to afford it. So are you hearing those concerns already? And do you think it's likely to be exacerbated as we expand treatment? And how do we mitigate that? Sorry, that's the other question, I suppose.
Yeah, sure. I mean, our forum, hepbcommunity.org, for people living with hepatitis B, is a global forum. So we have people from all across the world, and we definitely do run into people saying that they can't afford the meds that they were recommended to have. There are ways around it. For example, accessing PrEP as a way to get access to retroviral therapy, which is sort of allowed under the WHO guidelines as well. So we do have ways of accessing, or there are strategies out there for accessing meds when needed. I am not a public health expert, so I don't really know exactly how sustainable that is. But these are generics; they're generally cheap, and that is a real access issue that needs to be sort of addressed as we go forward with these.
I think there's a lot that we still need to learn about the community and their needs. So talking about which, Sital, I think inevitably as you expand treatment, you'll have conversations with patients who may initially agree to go on to treatment and have very good indications, but then don't necessarily adhere. I prefer the word adherence to compliance personally, and it's just a personal preference, but the adherence is an issue. What's your approach to patients like that?
Yeah, so I think each patient's totally different. Their rationale behind not sort of adhering to treatment will be very different. Certainly in London, we have a really diverse range of patients. Some have very differing health beliefs and perhaps, believe in more traditional type medicines. And so it's first about figuring out the real reason why they're not taking it. A lot of patients do go back home to their base country or that sort of where they've come from and just don't have access to medications or haven't taken enough, which can be an easy fix. It's here's our contact details, call us if you're going away, we can supply you with more. And the other thing actually about the guidelines, so a lot of these patients are young working people with demanding jobs, caring responsibilities. So it's about looking at, is it the frequency of visits that just puts you right off? Can we say, actually, do you know what? You can come back every year. You're really stable on treatment. I'll give you a year's worth of supply, because we've had patients that have just dropped off treatment because they just didn't have enough at home. So yeah, it's about probably exploring some of those individual reasons. And again, highlighting the benefits of treatment, or even if if they're not on treatment, but adhering to coming to see us in clinic for those surveillance bits, for some of, that more holistic review, talking about smoking, alcohol, all those other things that are going to affect the liver apart from hepatitis B. I think I sort of do try to explain that to patients, saying we're looking after all of you. And it also saves them a trip to the GP sometimes. So that can be quite useful. So yeah, it's very individual, but you do need to start then digging as to the reasons why.
So in what ways, I mean, I heard you talking, you sit down and you ask the patient what their priorities are to start off with, and
yeah,
almost reach a shared belief, sort of almost start with a blueprint of let's agree on what we can agree and then work up on that, correct? Is that
and what's achievable for them as well.
Yeah.
So yeah, definitely. That's a good summary, actually.
Good, thank you. No, that's great. So Markus, I think a couple of things in the guidelines are new, perhaps. One is the idea of treatment as prevention, which I think is really important, but maybe is underutilized. And the second is something Sital's already mentioned, which is about the monitoring interval. So can you give us a line about each of those, please, areas?
Yeah, treatment as prevention. I mean, the transmission is a reason also to treat, right? I mean, we have these individuals and persons who have extremely high viral load, no inflammation, very young individuals. Of course, they can transmit the virus. Of course, we have a vaccine, yeah, but maybe not everyone is vaccinated. We have migration, there's maybe communication, and young individuals may have a higher chance to transmit the virus maybe than older ones because they're active, yeah, in life. On the other side, the young individuals, they need to be adherent. This is a concern, yeah. Young men like to, party, maybe forget their pills. So you have to really talk to them, educate them, speak to them. I think this is a very important issue. And also from my patients, yeah. So there is some issues, and that needs to be considered, yeah, for all these problems, because if a patient with high viral load, yeah, does not take the medication, brings down the virus, if there's a relapse, can be a fulminant flare. So there can be jeopardize the patient. So that is very crucial to inform them, and that takes time, and that needs a specialist, that needs shared decision making, informed consent, and information to the patient. So this really needs dedication from the physician, yeah, and I think this is very important. The other issue you mentioned, so that was treatment as prevention, which is
and monitoring intervals. Sorry,
and monitoring intervals. So I think we have different kinds of monitoring. We need, of course, the 6 months intervals for HCC surveillance in those who needs it. That is important. You cannot just say come every 12 months if there is a patient with fibrosis, advanced fibrosis, cirrhosis. We have the PHB score, which is maybe simple to look at. But for those who have no fibrosis, on stable medication, who are adherent, completely agree, and we have this in the guidelines to extend the monitoring. That is, I think, important also, that we have also here a personalized approach, right, to the monitoring intervals.
Yes, I think you're absolutely right, and I think that it's great that the guidelines allow you to monitor less frequently on treatment, and we've recently, where I work, moved towards being able to give 12 months of entecavir, especially, but also even tenofovir, and actually I think that's made a big difference to some of our patients, and what we've done is alternate just a telephone visit sometimes to just issue medications, make sure the patient's okay, without blood test monitoring, and then done the testing once every 12 months. So I think there are unique and sort of more innovative ways of, rather than sticking to the rigid methods.
Maybe I have another issue also, not on treatment of prevention for transmission, but also prevention of reactivation. Sure. So there are more and more immunosuppressive drugs on the, in the market, I would say, or patients need more and more immunosuppressive drugs because they have rheumatoid arthritis, they have maybe received cancer therapies, and so on. And HBV is such an important issue to consider if you take immunosuppressive drugs, even if you have cured or functional cure of HBV and may still have some cccDNA which is not active, and so on. So I think this is also a very important topic, and we need also to educate our colleagues, in rheumatology, in oncology, neurology. Yeah, there are more and more immunosuppressive drugs also for multiple sclerosis now. They use B-cell depleting drugs. So this is so important because this can really save lives. Yeah, if we give in the patients they need, who needs it, the prophylactic treatment to prevent reactivation.
Yeah, certainly it's forming a bigger part of our practice, and we regularly discuss about 5 patients at least every week for reactivation purposes, because thankfully we've audited and we've convinced our colleagues to do so. But I think outside specialist centers that is still an issue, and for me, a reactivation that leads to a death is a tragedy that should never happen. But anyway, I think that's a really important point. Thank you, Markus. So I'd like to shift gear to something you spoke about, which is functional cure, and start maybe with the concept of functional cure and that phrase. And Thomas, the patient, and I know you've got some educational material about functional cure, but I think very much expanding treatments with NAs is start of the pathway to cure. So we know that in the initial agents that will be licensed will only really be used in patients already on NAs with certain levels of something called surface antigen, without getting too technical. But how do you explain the concept of functional cure to patients? I personally, as I say, don't like it. I don't think it's a cure, but anyway, how do you explain it?
How do we explain it? So the way I sort of go about it is to talk to patients saying that the majority of people clear their virus within 6 months. And in subsection of patients, you have it for the rest of your life. And a functional cure is essentially bringing you from someone who's a chronic infection to someone who essentially looks like they have naturally cleared the infection. And sort of that answers a lot of those questions about, what does that all mean? Okay. So I feel that that's a good enough sort of framework to do that.
So, but if someone then flips back to you, Sue, and goes, well, does that mean I never have the virus ever again?
Yeah. No, I think we're bringing up a good point, right? This is, and there's a balance, right? I think functional cure, like the word functional is just not easy to understand. And I know in the HIV world, they've decided like this is not a term they want to use for a number of reasons. And so, yes, I think when we look at the blood test, and I think we need to work on this, right? Because terminology across the societies is different. And some are using functional cure, other societies using occult infection, some are using resolved infection, for when it happens naturally. And it's confusing patients. And Thomas, on Hep B community, like, I don't know, last week, maybe a patient said, what am I? Like, they're like surface antigen loss. And they said, am I functionally cured? Right. This has happened naturally. Right. But we often don't use that term. If it just happens naturally, we call it seroclearance or surface antigen loss. Or they said, do I have an occult infection? So we got to figure this out, right? Because it's confusing patients. Any patient can Google anything nowadays, right? On PubMed, they can see all the conversation we're having. But I do liken it to similar to what happens with varicella and zoster, right? You still have the infection is indolent. It's not really active. It's not in your bloodstream, but it can reactivate, similar to how people get shingles or zoster. So it's I think that's a concept that we can kind of latch onto. But we do. Sherry Cohen, after we last had the conversation at the Hep B forum, said, my concern about removing functional cure completely is that people need that like drive, like hope, right? We've been talking about this for years, right? There's a hope of cure, and we're calling it functional cure. So we do have to weigh that out to like, we don't want to take that away also, right? Because there's a lot of hope in that. And losing surface antigen is a big deal, right? Because that's often what leads to stigma and discrimination, because that's the test that we use to document that somebody has hepatitis B. So, but I love how you said that being on an NA is the path to cure, right? And I think that's an important message for patients, that don't wait for a cure, right? Because at this point, at least do something to keep your liver healthy. A lot of the new medications may require you to be on antiviral medication too. So I think these are important messages. And I just want to take a step back I think this is the EASL guidelines and the other guidelines are a great time to reshift and kind of think about our approach. And I love how the EASL guidelines start off with, in principle, anybody who has hepatitis B with viremia could be treated, right? I like that that kind of changes the way we see things. We've been telling people like, oh, you don't need treatment, in a way that's more like, prove to me you need treatment. I need to do numerous blood tests over the course of years to see if you reach that threshold. And now we're saying, you know what, maybe prove to me you don't need treatment, right? So if let's go ahead and offer it to you. Let's start, and see, rather than lose people, as Markus had mentioned. And I think one of the things we've noticed from doing surveys of patients is, like, I think as physicians, we all think we're already doing shared decision-making, right? They're like, this is already like a principle in medicine. But when you ask the patients, a lot of them have said that nobody ever talked to them about treatment. Nobody asked them if they wanted to be more involved in the discussion. Like, I think one of our surveys for the WHO guidelines, 80% of patients said they wanted to be more involved with the decision. And the majority have actually said, my doctor never talked to me about treatment. So we do have to be very, deliberate about saying, hey, there's a decision to be made, and let's talk about it, and then let's reach this decision together. So I think that's going to be something good we need to train people about too.
Okay, so Sital, maybe I can ask you this next bit. So my conversation with patients has changed over the last few years. So before, let's say 10 years ago, I'd say, I'm starting you on this medicine because I think you need it. You're going to be on it indefinitely, unless you're one of the lucky 1% per year who cleared surface antigen on treatment. But now with the prospect of functional cure, I think the conversation changes. Has it changed for you, and how do you frame that?
Yeah, no, definitely. I think it's definitely changed over the last 3 or 4 years, and I'm very fortunate to work in a centre that also offers a portfolio of clinical studies. So I think we've, are very much encouraged to talk about everything in relation to treatment. I think now when I start, I say, look, you are starting treatment, and for now it's possibly going to be lifelong rather than definitively going to be lifelong. I think I was definitely more sure about saying that 5-6 years ago, but also giving that bit of hope, because there are a good portfolio of clinical studies that are coming through. So now I sort of say something around, actually, we are looking at cure. We are doing something proactive about trying to get patients off medication at some point. Although, that's not going to happen in the next few years, we're definitely closer to it now. So I think it's really important to open up and change the conversation around, well, we're just going to stick you on this treatment and that's it for life. It's much more than that now. And I do think even if you don't work in a centre that can offer clinical studies, do link in to your local centre that does. I think it's really important not to exclude patients that aren't at specialist centres to get access to some of those innovative therapies.
So Markus, I mean, your perspective in terms of recruiting clinical trials, I know you're involved as well.
Yeah, I think people would love to, be cured, that's for sure. Maybe cannot promise completely, because I always tell them, if we then deplete your immune system, that is the test if you're cured or not, right? The test with rituximab would be the proof if someone is cured.
Don't do that.
We don't want to do that. But this is actually, I mean, the comparison to zoster or shingles, I mean, is fair. I think that is a nice way to explain it, right? You are also healthy if you have if you had shingles, and if you're getting older, if you have immunosuppression, you can get zoster. So we need also to take care of this. There's also now a vaccine. Maybe in the future we get maybe also a therapeutic vaccine to prevent this. Who knows? Yeah, and I think that is a way to communicate. That's at this stage is a complicated virus. We cannot guarantee cure, but we have new drugs, and some patients, of course, are a bit hesitant if they are phase 2. They want to see more data because they're concerned. I have my pills. They have no side effects, which is good. Right, but yeah, I'm feeling good. Maybe I wait, for the next data. Some of them want to do the studies, and they acknowledge what we are doing, and they want to participate in research. So it's this and this. You need always to talk to the patient. That is important, to educate them, to inform them in much detail. Of course, we do not want to harm the patients with new medications. That's for sure. We need the accurate studies. I think that is for sure. And some of the new drugs, we have to be careful, of course, because they involve immune modulation. like checkpoint inhibitors that are also considered with lower doses, of course, and you need to tell the patients we have to use lower doses. We monitor your, of course, that is more challenging. Yeah, we have our patients sometimes come 2-3 hours away, and then suddenly in the clinical studies they need to come maybe first every week or every 2 weeks. Yeah, it is more challenging than to come every year. Yeah, if they are on stable nukes, and these are the challenges we have, and for the clinical studies. So it's a long way.
Yeah. I agree. So it's all about shared decision making. It's all about equity. It's all about offering the choice. And actually, it's all about not assuming, I feel like, that the patient in front of you won't be interested. So I think have that discussion, I think, is really, really important, because you'll be surprised sometimes who isn't interested. And I think that's really important. But anyway, great. Thank you very much, everyone. I think we're running out of time. I think it's been a great conversation. I think it's great to have these new guidelines, because it will change the way we talk to our patients. It will change who we offer treatment to. We're going to be treating a lot more people. We can have conversations about the logistics of that, about but fundamentally, I think it comes down to that consultation between you and the patient in the consultation room, whether that be virtual, whether that be face-to-face. And I think we need to learn and carry on and focus on that shared decision making. So really, all that's left for me. So thank you, Markus. Thank you, Sital. Thank you, Thomas. Thank you, Sue, for joining me for a very stimulating conversation. Next week's episode is about AI in hepatology, and about what is it really going to deliver and what's all the fuss about. So please, actually, unfortunately, it's me moderating again. You'll have to put up with me for 2 weeks in a row. So please join us for that, with a real expert panel, talk about one of the hot topics in the world in general, but in hepatology specifically. Thank you very much for watching, and wish you a good day. Bye-bye for now.